webinars aimed at community palliative care teams and those of you who are providing nursing home, social care and hospice care. These are Cardiff University provided webinars and Cardiff and Vale funded for staff working in the Cardiff and Vale Health Board area. Any IT issues, contact us through the chat and we will try to help. We will monitor the chat. But if you've got any specific questions, which we hope we would have time for at the end, then pop your specific questions in the Q&A part of Zoom if you can. I would be really grateful if you could all fill in your evaluation forms at the end, because it informs what we do with future webinars and how we manage this. This is due to run until 2 o'clock for the actual webinar bit, and then until 2:30 for anybody that would like to discuss cases and patients. The webinar part will be recorded. The cases and patient part will not be recorded, but even though it's not being recorded, we need people to maintain patient confidentiality at all times and to anonymise anyone or anything that they're discussing. But thank you very much. I'm now going to hand over to our main speaker for today, who is Dr. Margaret Capel, who is a consultant in palliative medicine and they lead for City Hospice, who provide community specialist palliative care for the City of Cardiff. And the person sitting with her is the lead nurse from City Hospice, Terry Ghazi. Margaret.
Thank you, Jo. So we have a busy hour ahead of us, and what we're going to do to start with is think about which people may benefit from referral to specialist palliative care services. We're then going to think about some very specific symptoms, that of pain and constipation. And as Dr. Hayes just mentioned, we'll finish off with questions and answers at the end. So the WHO considers palliative care to be the active total care of patients not responsive to curative treatment. The goal being to control pain and other symptoms to achieve the best quality of life for those patients. Now, a palliative care approach is something that probably the majority of you listening to this webinar take. It's that delivered by any healthcare professional as part of their normal clinical care. So specialist palliative care services and specialist palliative care professionals are those healthcare professionals who have additional specialist training and experience in managing palliative care. We also have the benefit of working in a multidisciplinary team. And certainly, when we're managing patients with the distress caused by total pain, we break down the pain thinking about the physical, the psychological, the social, and the spiritual challenges that that person's experiencing. And by addressing each of these in turn, we hope to resolve the person's problem. So which patients may benefit from a palliative care referral? Apart from those who, as we've mentioned, have an MD, who require the services from an MDT. And in our multidisciplinary teams, we have doctors, clinical nurse specialists, occupational therapists, physiotherapists, welfare rights officers, social workers. So we have a number of professionals to address those needs. So some of you may be familiar with this slide. We're looking here at illness trajectories. The circle in the middle represents the workload of an average GP practice, respecting the fact that the bulk of deaths actually come not from cancer, but from a combination of frailty and organ failure. Yet in specialist palliative care services, the majority of patients that we tend to see have a cancer diagnosis. And if we stop to think why that might be, it's possibly because their illness trajectory is slightly more predictable, as you can see on this slide. People with cancer, when they're approaching their end of life, are falling down that slope towards death. And sometimes that's obvious from how you see the physical changes in them. Sometimes you can see the progression on scans that the person's having as part of their cancer treatment. And sometimes it can be because the oncologist has actually stopped the treatment because the person isn't benefiting from it. However, people with non-malignant disease also have a similar symptom burden as patients with malignant disease, but it can be much harder to recognise when that dip in health actually is happening. And sometimes the clearest indication is asking the patient, okay, How were you 6 months ago if I'd met you then rather than now? Could you go up the stairs? Were you able to go out? Were you able to look after yourself and attend to your personal needs? And that rate of functional deterioration gives you an idea of the rate of change and how steep that slope is that you're looking at on the graph. Another way of looking at it, particularly for non-malignant disease, is looking at some of the criteria that are out there, such as the gold standards framework, or this one, which is the supportive and palliative care indicators toolkit. And they, if your patient has the features under that particular disease, then you may wonder whether they may benefit from palliative care involvement, or indeed whether they are progressing towards end-of-life care. And certainly if symptomatic, you might want to think about referral to local palliative care services. So, who are your local palliative care services? If the patient is in hospital, we have hospital palliative care teams, both in UHW, UHL, and Velindre. Now, the only inpatient hospice beds in Cardiff and the Vale are located in Marie Curie Hospice in Penarth. However, for community services, it depends very much on the geography of where the patient lives and which GP practice they're registered with. And I'm just going to hand over to my nursing colleagues to tell you a little bit about those. So Terry first, perhaps.
Hello. So as Dr. Capel and Dr. Hayes have mentioned, City Hospice is actually based in Cardiff, and we are a team of specialists, nurses, doctors, occupational therapists, social worker, welfare rights, and we've also got an army of volunteers. Our counselling service deals with our patients and their families, and we also offer children's pre and post bereavement. Families known to City Hospice can also access reflexology and hypnotherapy. For referrals, they can be by fax, by letter, or by telephone. Our website has a lot of details on how you can refer to us, and it's also got a form on there which you can download and email. If you're in doubt about any referrals, we're always happy to talk about them on the telephone. I'll now hand you over to my colleague in Marie Curie, who can tell you a little bit about her referral service.
Yeah, we're based, Marie Curie Clinical Nurse Practice, we're based in the hospice, and we cover patients in the Morgan geographic area. So we're a small team, but we cover any patient that lives in the Western Vale, Barry or Penarth, and Surrey. We receive referrals as City Hospice colleagues receive them by a referral form. We have got access to other services. We've got a family support team who offer emotional support and provide children's services as well, along with bereavement support, and they can go out to see patients at home. We're supported by our consultant, Dr. Jo Hayes, and we've also got access to occupational therapy, physiotherapy as well, and we cover a 7-day service as our colleagues in City Hospice.
Thank you both. So moving on to think about symptom control then, let's take a look at pain to start with. So I'd like you to consider this person. She's a 68-year-old lady with metastatic breast cancer. She complains of pain in her right posterior chest wall, and she's had a CT scan the week before we see her in clinic. The CT scan, so she's got disease in her right pleura, involving the rib below this, also in her liver, T5 thoracic vertebra, and S1. So she describes a continuous ache with sharp moments, and it's not pleuritic, the pain. On examination, she's got decreased air entry at the right base, no bony tenderness over her spine at all, and she has a normal neurological exam. So what I'd like you to do is take a moment to think about what you would do to manage her pain. Now, obviously, as taking a pain history, there are a number of acronyms that you can use to help you think about things. Those include things like PQRST, or you may be familiar with the EMA, approach to taking a pain history. But all of these are aimed at identifying the cause of the pain in order to identify the right analgesic. And then we're going to explain to the patient what we think the cause of the pain is. So at this point, the lady's taking the maximum dose of cocodamol in addition to 3 extra doses of Oromorph. So the important questions we need to think about and ask her: is the Oromorph effective for the pain control? And the answer is yes, it is. It takes the pain away completely. The problem is it's not lasting long enough. So she's having to use the Oromorph in between the cocodamol. Next question to think about: does the symptom she's describing correspond with a known site of disease? And the answer is yes, it does. It corresponds exactly with where we know that she has this pleural disease and the rib involvement and possible nerve involvement. So although there's the artificial nature of presenting this as a talk, I can tell you that there were no suggestions for both examination and the history to suggest she had either a chest infection, pulmonary embolus, or pleural effusion here. So let's then think about the total dose of morphine that this person's taking. So she's essentially already on step 2 with a little bit of step 3 of the WHO analgesic ladder. She is, on questioning, completely compliant with her medication. She's taking it regularly, the cocodamol, breakfast, lunch, tea, bedtime, with the Oromorph in between. So let's think about how much morphine this codeine equates to. So codeine is a prodrug of morphine. Your body works the codeine by turning it into morphine, which is reassuring for her when I'm talking to her about putting her on a long-acting dose of morphine. So the drug equivalence, therefore, is add up them all the codeine, so that's 8 times 30, and divide by 10, which gives us 24 milligrams, and then add up the extra Oromorph she's taken, which is 30 milligrams, which gives us a grand total of 54 milligrams. So what I want to do is start her on 30 milligrams BD of MST, long-acting morphine. At the same time that we prescribe this, we're going to give her a laxative and an antiemetic, because those cover the main side effects of morphine that we would anticipate her experiencing. So this was effective for her, and she has been stable on this for a long time. However, there are times when we might want to think about an alternative analgesic approach or adding in an adjuvant. So ESMO and NICE all recommend that your first strong analgesic on step 3 of the WHO analgesic ladder should be morphine. And even if the pain is neuropathic or partially neuropathic, such as in the last case, morphine is generally effective for that. However, there may be circumstances when you might think you want to add in an adjuvant. Those might be that you're titrating the morphine up over time and the person is experiencing more side effects from it, or unacceptable somnolence, or you have problematic pain control. So you may wish to block one of the points along this pathway by adding in an adjuvant analgesic. So for neuropathic pain, generally speaking, if we think there's nerve compression, we might approach it with steroids, with dexamethasone in the first instance, and perhaps contact the oncologist if we think that there's a possibility that they might be able to do something interventional to improve the pain control. The next neuropathic drug we might think about then, if we don't wish to use steroids, might be amitriptyline or gabapentin or pregabalin instead of gabapentin. And that would be the general approach to starting neuropathic drugs in this circumstance. So moving on to our next case, this time we have a 64-year-old man who's known to have metastatic colon cancer. He's had treatment and has responded well to treatment. So he comes back to clinic for follow-up. And at this point, he's actually on a treatment break. So when he comes back to clinic, he reports a 3-week history of really severe pain and weakness in his neck and running into his left arm. The pain is stopping him sleep, and he's actually restarted the cocodamol that he had left over from his original diagnosis and treatment. So unlike the last case, this is a new pain. We don't have an explanation for it. And in this person's case, we have both motor weakness and possible nerve compromise. So until proven otherwise, the thing that we're most concerned about is whether this person could have metastatic spinal cord compression. So if we think about it, we're going to examine this person, and actually he has bony tenderness over his lower cervical spine. We can pick up some weakness in his hand, but if we think about that and relate it to the anatomy that we know about, we know that anterior nerve roots coming out of the spinal cord are supplying the motor function, and posterior nerve roots are supplying the sensory function. So going on to perform that neurological examination, the area that looks like it's compromised is the C6, C7, C8, so the bottom red ones on this slide. And you could actually identify that he had weakness in his wrist and thumb. Now, this is an oncology emergency. And in the community, it can be quite a challenge getting the person to see the right professional in the hospital, because it is essential that they go to hospital and have an MRI scan of their whole spine that day. Unfortunately, as things stand, there isn't a defined pathway from community to MRI scan. But in this person's instance, I was fortunate enough to find a responsive trauma and orthopedics professional who did arrange the MRI scan. I also let know the acute oncology team in UHW, so they were able both to track through and follow the person's MRI scan and then alert the oncologist to the results so that the person ended up with the right treatment. Now, spinal cord compression is a common neurological complication, estimated to be somewhere within 5 to 10% of cancer. And unsurprisingly, it appears to be most common in the cancers that we see most commonly in the community, that is lung, breast, and prostate. The site of the cord compression will determine the symptoms and signs, as you've seen with the last chap that we've talked about, with the weakness in his hand and his forearm. However, the majority of spinal cord compression actually occurs in the thoracic spine, so this was slightly more unusual. In terms of how people present, the majority of people present with pain, and where people have looked back in studies and literature reviews, actually the back pain can precede neurological signs by up to 2 months in advance. Now, just because a person is walking doesn't mean they don't have cord compression, and that's sometimes something that you as a professional, particularly if you work in the community, need to articulate when you're referring that patient on to somebody in secondary care. You need to make it absolutely clear what you're worried about in the person's house, that this person might have spinal cord compression and they do have a malignant diagnosis, so that they're not turned away by mistake from A&E or whichever service is reviewing them in secondary care. Now, if we think about the red flag features you may wish to look out for, the man I mentioned had both the localized spinal tenderness over his lower cervical spine, but he also had the nocturnal spinal pain preventing sleep. But any of those listed on this slide should be a red flag to you to think about what might be going on. Now, metastatic spinal cord compression has both bone and neuropathic elements in terms of pain, but we would still approach it in terms of pain management in the way that we've discussed in terms of working up the WHO ladder. In terms of warning symptoms, radicular pain is more common than the others, but patients often describe this peculiar loss of sensation in their feet or their fingers, and particularly with feet, people say it's like walking on eggshells. So the sensory disturbance initially can be that subtle. In terms of the examination, it can be up to 5 dermatomes below the level of the cord that's compressed that you may be able to pick up altered sensation. Now, Cauda-Equina syndrome can be more difficult sometimes to identify. If we remind ourselves that the spinal cord ends at around L1, L2, what we're talking about here is nerve compression below that level. And that can be manifested as the features on this slide, but more commonly in the community, when you're examining someone, it can be unexplained urinary retention. And the patient says to you, I can't pass urine, or I've been passing very little over the last few days. And when you examine them, you can find a distended bladder. It can also present as fecal incontinence. And you can, when you do a PR examination, you may notice that as sphincter disturbance. So again, people where you suspect this need a neurological and an abdominal examination. And it's really important to document the findings, both positive and negative, from the examination, because this is missed Cauda equina syndrome is a common source of litigation. So the purpose of treatment, even in palliative care, because as we said, this is an active total care of the patient, is to either improve, restore, or maintain that neurological function despite damage to the cord. We want to reduce pain, and we want to preferably prevent local recurrence of the cancer at that site. Now, if the patient declines admission, it's absolutely essential that you explain to them the consequences, i.e. the potential loss of function of the limb or below the level that you think the cord is compromised. Do we refer in palliative care every patient that we see that we're suspecting spinal cord compression for investigation? The answer is obviously no, we don't. Those people that we perhaps wouldn't refer would be those who we can foresee they are actively entering their last days of life, and they wouldn't benefit from admission potentially to hospital or investigation, or live long enough for treatment. But it would be a conversation that we might have with them at home and sensitively explore how to manage their pain and their function. So moving on from cord compression then, let's think about other people that we see commonly in the community and how we would manage their pain. So this lady, for example, has a glioblastoma. Over the course of the last week, she has a more pressing headache, as she described it, and she's become less mobile. So essentially what she's describing is neurological deterioration and a headache. Now, the astute among you may notice that the oromorph dose that she's taking is just 2.5 milligrams, which is insufficient for the amount of long-acting morphine that she's taking. So whenever you prescribe long-acting morphine for a patient, the patient should also have access to breakthrough doses at about 1/6 the total dose of morphine that they are taking. So in this lady's instance, she should have 10 milligrams of oromorph as her breakthrough dose, not 2.5 milligrams. Now, there are a number of potential ways to approach this. Asking her, what was the last dose of steroids that you were on that you didn't have this deteriorating in function? And it transpired in conversation that she was taking 4 milligrams 2 weeks before that, and she had been more mobile and had better control of her headache. So her blood sugars were fine on checking. She's tolerating the dexamethasone, and we elected to go back up to 4 milligrams of the dexamethasone and use the oromorph at 10 milligrams as necessary, with the intention of titrating the long-acting morphine up over the next week or two in direct proportion to how much extra oromorph that she used. Now, if any patient who's on long-acting opioids stops swallowing, you will need to change the route that they are taking their long-acting analgesia. The 4th webinar in the series from Cardiff University will address, I think, syringe driver conversions and managing conversions in the end of life. So I wasn't planning on doing that today in the interests of time, but it's worth remembering that that is necessary. So if we think then about visceral pain, this man, a 68-year-old man with cholangiocarcinoma, with right upper quadrant pain. Now, when we first met him, his liver function was pretty much normal. So essentially, we started with some oromorph, just 2.5 milligrams, and titrated to a very low dose of MST. However, over time, what he noticed was that he was becoming more somnolent, and it was affecting his quality of life. And if you look at his blood tests, you can see his liver function deteriorating. So we could add in at this point an adjuvant. So our options for liver capsule pain, because that's essentially what we're talking about here, is we could think about dexamethasone with a proton pump inhibitor, or a non-steroidal with a proton pump inhibitor. If we're going to use the non-steroidal, we would want to check his renal function before introducing it, and possibly again in 2 weeks' time to check that he's tolerating it. In this case, because the man had a reduced appetite, what we chose to do is introduce the dexamethasone. And what we found was that we didn't require any further increase in our MST, our long-acting morphine. Now, in the context of liver failure and deteriorating liver function, there is no ideal opioid choice. If you think about it, all drugs have to be metabolized through the liver. So what you're sometimes better off doing is using a short-acting opioid and going low with it to start with, and ever so slightly adjusting the dose over time, depending how the person tolerates it. And again, because the liver function may deteriorate even further as time progresses, it is a question of close and active monitoring and adjustments around how the person is. But definitely in terms of the literature and the European teaching, even in the context of liver failure, morphine is still the first opioid of choice. So what does then differentiate which opioids when we choose them? So there are equivalent doses for all the strong opioids. So for example, 60 milligrams of oral morphine is roughly equivalent to 30 milligrams of oral oxycodone. But what you'll notice from this slide is that the opioids actually bind slightly differently to the receptors. And we can exploit that in terms of which opioids we choose when a person has side effects or intolerances. In the context of morphine, you'll notice that it says the metabolites accumulate in renal failure, and they do. Those metabolites would be morphine 3 and morphine 6 glucuronide. Morphine 3 is not an analgesic, and we think it probably accounts for the sedation, respiratory depression, and sometimes the twitching, the myoclonus that you might notice if you use it in someone who has poor renal function. The half-life of oxycodone is also increased in renal failure, but one doesn't get quite the extent of side effects that you do with morphine. So, if we think about this person, this man had metastatic prostate cancer. He did have an MRI to prove that he didn't have core compression, but did indeed have bony disease. And initially, he was having, as you can see, dialysis 3 times a week, as he had established renal failure before his diagnosis of prostate cancer. So we started with step 1 in terms of managing his bone pain. On the WHO ladder, we used paracetamol. And over time, that was insufficient. And we moved up to oxynorm, or short-acting oxycodone. We use 1 milligram to start with once a day. And again, over time, as things progressed, that moved to 2.5 milligrams twice a day. And note, we're spacing out the dosing interval here, and he's still attending dialysis 3 times a week. Now, this was a very challenging case because between his prostate cancer and treatment for that and dialysis, there were times when he would attend hospital because he was either septic or he'd missed dialysis. And I think it's really important how other professionals communicate with patients in these circumstances. Not all the symptoms and problems a person runs into are related to the opioids that they are using. So sometimes unhelpful communication saying, actually you're unwell because of the oxycodone, when actually the person has a temperature of 39 and they are septic, is not necessarily the most helpful thing a person could hear in these circumstances. Because certainly in the community, we are all, aren't we, going to have to carry on using and managing this man's pain and using analgesics of some sort to address his pain control. So it's using the opioids safely is what we want to do. So when we reached about between 5 and 7.5 milligrams of oxynorm twice a day, we talked to him about going on a long-acting opioid. And that we chose was fentanyl, because fentanyl, the majority of the fentanyl patch is metabolized through the liver. It doesn't accumulate in renal failure. So he went on to a background fentanyl patch at the lowest dose and then retained his oxynorm to use for breakthrough pain only if he needed it. And he only required it once, twice a day at most. So if we think about fentanyl patches for a moment, a fentanyl patch lasts 72 hours. Its half-life, if you pull it off, is about 17 hours. They were never designed to titrate a patient on. So if you do need to titrate a patient's pain control, it's better to use either morphine or oxycodone or some short-acting opioid, establish how much background they need, and then rotate them across to fentanyl. I'm sure nobody listening today would think about starting an opioid naive patient on 30 milligrams of morphine. And that is the equivalent, roughly, that the lowest fentanyl patch is. So again, these patches are not for the opioid uninitiated. And again, if you are using them or you're looking after patients with them on, very important not to put things like heat packs, hot water bottles, or put them in hot tubs or showers, because it does cause a release of the fentanyl through and into the system. So moving on, yes.
I wonder if we could just pause there for a minute and see whether anybody wants to put any questions into the chat. I don't think there's anything in the chat at the moment. And also, I didn't run our polls earlier, so I thought if we just had a sort of a mini breather in the middle, and I would see if Charlotte was there. Charlotte, are you there? So I wonder, guys, if you could just, so that we've got a little bit more of an idea of all of our audience listening to us, whether you could just fill in the poll there so we have an idea of what the backgrounds are for everybody. Thank you. And I think a little bit later on, it'll talk about your setting as well, because I know that some of you are probably from nursing and residential homes or from social care, as well as our GP and district nursing colleagues. Thank you. Okay, we've probably got most people who've participated there. So we have got the majority of people listening are GPs and GP trainees, and then a fair chunk of nurses there, and district nurses, and then some of our palliative care team colleagues. Thank you. Thank you, Charlotte. And do you want to run the next one? And while you're filling these in, if anybody's got any questions at all on pain control or anything else that you want to ask about from the stuff that Dr. Capel's just been talking about, do you want to just pop any questions you've got into the chat?
Just to say as well, if the question has a lot of context about it, we can unmute you as well if it's easier for you guys to ask a question verbally rather than type it in. Just raise your hand or let one of us know.
Thank you. So most people are working in the community, which is no surprise because that's how we have sort of marketed the webinars, and you're the people that wanted to talk to because you're talking to your community palliative care teams mainly. We've got a few people from nursing homes there, which is great. Thank you for joining us. And some colleagues there from secondary care, which, you know, for things to work in the community, we need our secondary care colleagues to have an idea of what it's like they're out in the community trying to provide care. And by the same token, those of us who are in the community need to have a good idea of how things work in secondary care, because we've all got patients going in and out of all of these settings and are needing to transfer care between us. Thank you. So I don't think we've got any particular questions at the moment, so I've stunned everyone into silence. Is there anything that any of our panelists wanted to add at all before we just go on to the next bit? Nope. Okay. Thank you very much. I'll carry on then, I think. I'm sorry for interrupting, Margaret, but I just thought it would be good to have a little pause there. So thank you. I'm going to hand back over to Dr. Capel then to carry on with our talk this afternoon.
No problem. Okay, so moving on from pain, let's think about constipation. So constipation is a subjective experience in that it relates to both a decrease in the frequency of bowel habit, as also in addition to difficult passage of motions. So when you're talking about this with a patient, really important to establish what's normal for them before the illness, before treatment, before everything else has taken place, because that's essentially what we're trying to aim for, that or something near as we can do, that the person is more comfortable. So if we think about managing constipation, exactly like pain, it's thinking about what are the possible causes or what are the contributors to that symptom. And if necessary, it may require investigations, and it may require treating reversible causes, such as hypercalcemia or non-drug problems, things like the lack of privacy, very often working in the community. When a person is deteriorating towards the end of their life, it may be that things like the hospital bed is in the lounge and the commode is next to it. And people do say that they're really embarrassed or self-conscious about using that, with family and other professionals coming in and out of people's homes. On a ward, obviously that's difficult because sometimes we have the non-soundproof curtains between people. So same principle, the lack of privacy can be a huge problem for people when they're trying to open their bowels. Where possible, we stop constipating medicine, and we're going to look at a slide in a moment which lists just the common ones that we see in the community. But essentially, in terms of signs, people often report things like pain, which could be a continuous ache or a colicky in nature. Sometimes it's altered urine stream, particularly in men, either urinary hesitancy or straightforward urine retention. Now, it's important to remember that constipation doesn't give you large volume vomiting, increased bowel sounds and tinkly bowel sounds, or significant abdominal distension. Those aren't signs of constipation. And if that's what you're seeing, then that does merit investigation and thinking about what is actually really going on here. So let's think about this case and think about what to do. So this is a 65-year-old lady with metastatic melanoma. She had a CT which showed that she had disease in her omentum, her peritoneum, also subcutaneous nodules and liver metastases. So at this point, over time, she has got herself onto 120 milligrams of oxycodone BD. So that's long-acting OxyContin or Long-Tec, maybe more familiar with, in addition to pregabalin. Now, conventional teaching and RCT suggest that you can actually start managing constipation with a stimulant alone, such as something like senna. But in her case, what she described was that it was like passing house bricks, as I recall. So we used to give her senna and docosate. Her bowels were opening on that regime every second week. Before the oxycodone and before the treatment, it used to be every day and sometimes twice a day. When she was in hospital as part of her treatment for systemic anti-cancer therapy, she responded very well to having enemas, and she came home with the planned regime, and she got to the point after the first week that she found having enemas on a daily basis or even 3 times a week incredibly degrading, and she didn't wish to carry on doing that. We tried suppositories so that it would be her applying these rather than a healthcare professional applying them. And again, after about a week or 2, she just felt that this wasn't something she was able to continue with. We tried Laxido, and for her, she got to the point where looking at the glass of Laxido, she said would make her vomit just thinking about it. Plain films and the CT scan and clinical examination showed that she wasn't obstructive. And so what we're thinking here is that she probably has a high proportion of opioid-induced constipation in addition to the disease. So let's look at the slide and think about which of these areas actually apply to her. So I told you she doesn't have bowel obstruction. She does have painful defecation. Her calcium was normal. But as we know from that CT scan, she has a lot of disease in her peritoneum. And you can feel, when you examined her, you could feel doughy masses. And it's those that are definitely contributing to the difficult passage of motions. In terms of her inadequate diet, she'd long given up things like bran, and she struggled to manage 3 litres of fluid a day. Initially, she could mobilise to her toilet, but over time, it became the case that she had that commode next to her bed, a hospital bed in the lounge downstairs, and she found this incredibly undignified. We stopped her iron. She was on the, in terms of the drugs, on the right-hand case of the slides, the oxycodone is quite clearly an opioid, and the main side effect of that is constipation. And when she stopped her systemic anti-cancer treatment, we were able to stop her 5-HT3 antagonist, which may be more familiar to yourselves as things like ondansetron, which she used as an antiemetic. So if we think then about what laxatives we can give her, Fibergel has a very limited role in palliative care. It's a bulk forming agent, which in order to work adequately, you need to manage decent volumes of plain fluid with it. She's tried the glycerin suppositories and we've moved on from those. She's taking docosate, which is just a surface softener. We stopped lactulose quite early on in her management of laxatives because she found it made her quite gassy and gave her quite a bit of distension. Magnesium preparations worked extremely well for her for a significant amount of time, but unfortunately, and you may have come across this yourself, there has been a significant shortage of magnesium worldwide, and so it can be quite hard to get hold of things like magnesium hydroxide, magnesium sulfate regularly at the moment in the community. She's intolerant of the Laxido, and so we're left with things like Senna and Bisacodal, or this drug at the bottom, these naloxegol. Now, I don't know how many of you have come across this, but what we find is that for naloxegol is a peripherally acting mu receptor antagonist. So that is, if we're saying that this lady is taking oxycodone, part of the way that opioids cause constipation is that they decrease peristalsis, they increase the transit time that the motion is in the colon, they increase anal tone, and they cause greater drying and reabsorption of fluids of the motions while they're in the colon. So by using or thinking about adding in a pamora at this point, such as naloxegol, what this drug does is it antagonizes the effect of the oxycodone in the colon. So what we're doing is we're not losing central pain control, but we're antagonizing the effect of the opioid in the bowel. So this was a trial. You can only use these drugs if a person isn't obstructed, for example. We tried it for 2 weeks, in addition to the Bisacodal and the docosate that she's taking. And actually we found this quite successful for her and an acceptable option. So she took the medication once a day in addition to those, and she was able to open her bowels 3 to 4 times a week. So I would consider that a success. Now, naloxegol is better known as Moventic. It's an oral tablet. They're worth knowing that there are subcutaneous preparations available, which some of our district nursing colleagues who are present on the talk today may be more familiar with and have given in the past. So moving on to, if you like, the ultimate consequence of constipation could be fecal impaction. So again, to identify this, you need to examine the patient and you need to do a PR. It can present with overflow diarrhea, which is also where the PR becomes important. And then the problem is sometimes compounded because when you hear that the person has diarrhea, unless you examine them and think about it and take a history of constipation and bowel action, the temptation is to give the person loperamide, which can obviously make the symptoms worse. So to manage fecal impaction, you have options. In terms of rectal measures, you can think about either glycerin as a softener and bicocodal suppositories as a stimulant. And that can be particularly useful in that order if when you do a PR examination, the person has a hard motion. On the other hand, if there's just a soft motion in the rectum, bicocodal might be appropriate by itself, or a small enema. So you could use a softener one day or one night, and the next day go back with a phosphate enema, and to help relieve to release the motion. The other alternative, if PR examination and intervention isn't acceptable to the patient, would be to use either Movicol or Laxido. So the way they work, you'd need 6 to 8 sachets in a litre of water, and you'd need to drink the jug of water over the course of the day. And that can be quite useful, for example, if you're certain that the person has quite significant constipation, but you can't palpate any motion when you do the PR examination. So effective and useful ways of managing constipation. So before we move on to questions, just a sort of final slide in terms of if you do want advice, because I appreciate sometimes you may wish to talk a patient or a symptom that you're seeing through, but won't necessarily feel that it needs referral through to either of our services. So for in-hours advice, you can contact either City Hospice or Marie Curie on the slide with the numbers we had at the start. If it's out of hours and you're a healthcare professional, you can get hold of the doctors via Cardiff and Vale switchboard. And obviously you'll be familiar with the out of hours services that Terry and Elaine run on the weekends, and that's through the out of hours GPs. There is an opioid dose converter. So we mentioned equivalent doses of opioids. If you want to look it up, the reference is there. And there are also palliative care formularies that are worth having in whichever group practice that you're in, for more detailed information on the drugs that we've mentioned today. Did you want to put, I believe, Joe, you have a slide, or is it Charlotte?
Charlotte, would you mind putting our evaluation slider and sharing your screen? Would that be okay? Thank you very much. We'd be really grateful, guys, if you could fill in the evaluation. As I said before, it will guide how we run the webinars going forward and give us an idea about whether we are covering the sort of stuff that you would like us to cover, whether you wanted us to cover any different things, and whether we need to expand the webinars and give you more stuff in the future. So please fill in your evaluation. And just as a reminder, in case anybody does need to leave early, I would like you to stay, that next week we'll be talking about the deteriorating patient reversible causes and challenging behaviour, which would be the same time next week. Thank you. So I'm going to go on to any questions in a minute, and then for anybody who wishes to stay and discuss some patients, we're going to do that in the last half hour. Just a reminder to make sure everything that you might discuss in that session is anonymised. Thank you. So my colleagues there who've been manning the chat and looking at Q&A stuff, do any of our attendees have any questions, or do any of you have any questions that you might have wanted to ask, or just comments that you might like to make?
So there's no questions at the moment, but I think, as just thinking about everybody, I'm sure has looked after people just like Margaret has been talking about. So just sort of think back to folks that you've looked after. Is there, and any questions you might have had, or at some point that you might have even have asked for some advice, do pop your hand up, pop something in the chat. I think, Margaret, one of the key things that you were saying, particularly around malignant spinal cord compression, is just how difficult it can sometimes be in the community when you're seeing people in their own environment, because there's so much else going on, and sometimes the signs are really subtle. But I think that key to what you were saying is what's changed. Actually, what's changed in how I'm walking, how I'm feeling, my pain and that sort of thing. I think that's the really crucial question, really. But it can be very difficult sometimes to disentangle what's new and in the middle of all the other symptoms that we're seeing in the community, particularly, you know, in colleagues in general practice, it's about really trying to nail it and actually, have I got a red flag collection of symptoms or even one symptom in front of me? Do we need to do this now? But once neurological function is lost, it can be lost and it can be lost forever. And people will remember delays and barriers and obstacles to getting things sorted at a very stressful time. So I don't know, Margaret or anybody, any colleagues really, is there anything else that helps you when you go in to see somebody or meet somebody for the first time and you begin to wonder about spinal cord compression? Are there any other tricks of the trade really that we can share with colleagues? And folks, do please pop your own questions in the chat and we will get to them as we can.
I mean, I think it's about having a low threshold, isn't it? Sorry, I'm James Davis. I'm one of the other consultants who works at City Hospice. So I think it's about having a low threshold, isn't it? If you know somebody's got known bone metastases, especially if they're spinal metastases, or has got a cancer, even if they're not known to have bone metastases that are at risk of that, it's having a low threshold. It's not to say that everybody with back pain and cancer, it will be malignant, but it's almost going in with that in mind and trying to prove or disprove one way or another. And I think that if the patient wants it and it is appropriate, and you can't rule it out in the community with your history and examination, is actually you're going to need to get that investigated, as Margaret said, as an oncological emergency. So I think it's probably the reason they're missed, or there's sometimes difficulties, is almost not having that in the forefront. And we're almost working your way backwards from that. If I've got someone with cancer and back pain, that's my first thought, and I'm trying to work my way backwards from the worst case scenario.
And Christie's asked, is there a spinal cord compression or red flag symptom checklist? In times gone by, there was a small credit card type of card, I recall, from Valindra, but I'm probably showing how old I am. So in terms of sort of red flag symptoms, I mean, Margaret, they were there on the slide. And anything else, any helpful mnemonics or anything else that people can think about?
I think sorry, I feel like I'm taking over now. The Macmillan website has a good patient information leaflet, and nice guidelines talk about people who are at risk or are known to have bone mets, that they should all have written information to back up verbal information. Doesn't always happen in terms of patients who are known to, say, oncology teams. I think it's not assuming that people will know about it, but the Macmillan website has a good patient information leaflet, and I sort of carry around a package of them just to give out to patients if I'm worried. It's more for the patients where I actually think this probably isn't. And I'm comfortable enough to say this probably isn't, because otherwise you're going away to investigate it. But if you see any of these signs, then you need to speak to somebody. And I feel better when I leave if I've done that.
Thank you. And thank you, Emily. Emily's put in the chat, there's a Valindra AOS, Acute Oncology Service app, available on the App Store, which also gives the red flags for malignant spinal cord compression and other oncology emergencies. And fantastic. Thank you very much. That's great.
And I've got it on my phone as well. It looks like that with the blue sign and the big, I don't know how well you can see that. The second from the top, the big V on the blue, on the blue background.
Okay, thank you. And I think, Margaret, what you were saying about transferring somebody into hospital from the community, the referral pathways and processes are at times a little bit ambiguous, but actually linking with our acute oncology service colleagues can be incredibly helpful. because they can track people down and make the links. I'm sure I saw somebody had raised a hand. Charlotte, I don't know whether it's possible to find or to open the microphone. I think it was.
I can't see who's raised their hands.
It was, unless whoever you were, I think it was Lloyda Henton-Jones. Lloyda, I hope I've said your name right. Is your hand still raised? We can open the microphone for you to ask a question, I hope.
I can't see who it is.
Whilst they're thinking about whether they want to speak out loud to us, Fiona,
Yes.
for anybody who wants to stay on the call, I have got, another spinal cord compression case of somebody that I dealt with recently that we could talk about if it's helpful in terms of the practicalities of where to send them, how to send them, what you might do whilst you're trying to manage them in awaiting transport and that sort of thing. But that depends on whether people want to cover that, really.
I wonder if then in the interests of time, because we're kind of the deliberate timing of the webinars is an hour lunch and learn. So I think the main thrust of the webinar, the main facts of the webinar now we will bring to a close, and then stay on. If people want to stay on, then you're very welcome to stay on. Please fill the evaluation form in. Joe, I don't know if there's sort of some final things that you want to say before we move on. I'd just like to say thank you to everybody joining the call, and thank you to Margaret for, again, a very clear collection of things for us all to think about. But over to you, Joe.
I think you've covered the things I wanted to say. I was going to thank our speakers, thank our participants, beg for more evaluation, and to remind people to join us next time, and to inform us about what else they would like. Thank you. So I think if we stop recording.